Hello, my name is Aislinn Hart, and today I will be discussing the evolving impacts of liver and intrahepatic bile duct cancers at a global, national, and state level. Liver and intrahepatic bile duct cancers are malignant cells that occur in the liver or bile ducts within the liver that connect the liver or the gallbladder to the small intestine. The most common form of liver cancer is hepatocellular cancer, which targets the hepatocyte cells in the liver. This is also the most just prevalent form of liver cancer within the United States, and it's largely connected to chronic hepatitis C virus infection. Liver cancer is a persistent and growing global health concern, and the etiology or the contribution of these different risk factors to the development of cancer is changing in recent decades. In 2020, liver cancer was actually the third leading cause of cancer-related deaths globally, despite being the sixth most diagnosed. And this kind of highlights that there is a gap between diagnosis and treatment for liver cancer, meaning that individuals aren't realizing that they have liver cancer until it's too late. These prevalence and incidence rates are expected to increase by more than 50% globally by 2040, and mortality rates also follow a similar trend. And not only is this a global trend that is seen in lower income countries, this is also trend that is being seen in wealthy countries, which highlights that a lot of the intervention measures that are being taken, they're not as effective because this has been a known and prominent public health concern for decades now. Risk factors for the development of liver cancer include hepatitis B virus, or HBV, or hepatitis C virus, HCV infection. In addition, excessive alcohol consumption can put you at risk for developing liver cancer. Excessive alcohol consumption can cause cirrhosis of the liver, which is another risk factor for liver cancer. And then there's also metabolic associated steatotic liver disease, which was previously known as non-alcoholic fatty liver disease, uh, or is an acronym MASLD. MASLD is the fastest growing um, prevalence globally. Um, and this mirrors the rise in obesity globally as well. This is something that we're seeing is contributing more towards the development of liver cancer in populations that have food, but maybe not as nutritious food. In the United States, food insecurity is extremely prevalent, especially in Texas. And so while individuals may be meeting their caloric intake, the general quality of their diet remains poor and puts them at risk for developing metabolic syndromes like diabetes, cardiovascular diseases, and liver diseases. In addition, genetic factors do play a role in how susceptible someone is to developing these conditions and the risk factors for liver cancer. Survivability of liver cancer remains low and largely unchanged globally, even in wealthy countries, as previously mentioned. Ways in which that we can address this low uh, survivability includes addressing the systemic things that contribute to liver cancer. So, addressing food insecurity, the current opioid epidemic in the United States, excessive alcohol consumption, all of these things, as a preventative measure, could decrease prevalence and incidence rates. Another thing to note is that, as I mentioned earlier, the general etiology of liver cancer is changing. So previously, HBV infection was a major contributor towards the development of liver cancer, just because rates of that virus was high due to things like unclean water. However, in countries with better water and food systems, such as the United States, there's been a decrease in HBV infections. However, HCV infections are one of the main contributors to liver cancer in the United States. And HCV infections can occur through intravenous drug use, which is why it is linked to the opioid epidemic. Additionally, the low survivability does point out a need for better screening. If we can catch liver disease or liver cancer in its early stages, or even risk factors for liver disease in their early stages, we can overall increase treatment and prevention measures and lower that mortality rate. In addition, there is a general need for screening just because vulnerable populations who don't have good healthcare access tend to have higher mortality rates than other ethnic groups. One ethnic group that has the highest mortality rate in the United States is the Hispanic and Latino populations. And that is despite the fact that they actually do have lower incidence and prevalence rates. States and counties that have higher Latino and Hispanic populations also tend to have, in general, to be like hotspots for the development of liver cancer. So in the state of Texas, counties that have higher Hispanic and Latino populations that border the Texas and Mexico border tend to have higher incidences of and higher mortality related to liver cancer. In addition, older adults also have higher incident rates. This is largely because the factors that contribute towards the development of liver cancer are chronic conditions, and you're put more at risk over a long term versus a short term. Some prevention or intervention opportunities for liver cancer include investing in harm reduction strategies. Harm reduction strategies are methods that can be used to reduce the spread of disease related to substance use disorders, as well as increase substance use disorders. So rather than pushing an abstinence-based approach, harm reduction strategies really focus on preventing disease. An example of that would be providing sterile needles to drug users to prevent the risk of contracting AIDS or HBV or HCV. However, many forms of harm reduction strategies are criminalized in the United States, and it's really up to the states on what they want to do with that. So, for example, in the state of Texas, things like providing fentanyl testing strips and sterile needles is illegal, and this really limits harm reduction strategies and how they can show up in these different regions. Uh, in addition, harm reduction strategies not only help prevent the spread of disease by giving people sterile needles or testing for fentanyl, but they also provide opportunities to connect those vulnerable populations with different resources by not encouraging abstinence-based intervention. So basically letting those individuals decide what their journey looks like towards decreasing substance use really gives them more power in how that plays out and provides healthcare professionals the abilities to meet some of their medical needs. In Austin, there was a program where there were clinics at several different sites that provided testing and screening for HCV among homeless populations and those that use intravenous substances. Although only around 10% of program participants actually finished the treatment for HCV, of those that finished, the majority of them were considered clinically treated, which did significantly decrease their risk for the development of liver cancer. There may be other factors also that contributed to the low rate of people who actually followed through with all of the treatment, such as just not being able to stay in one location, or maybe there was something else that was going on with that individual who was participating in that program. Just because only 10% of people actually followed through doesn't mean that that wasn't a substantial or meaningful amount. Another intervention opportunity to reduce liver cancer includes improved screening education. Many individuals don't fully understand the connection between risk factors and liver cancer. A study done on different health communication approaches among immigrant groups found that a lot of participants prior to the study didn't actually understand that HBV was a risk factor for developing liver cancer and meant that they should probably be screened for liver cancer. This also kind of indicates that there is a need for cultural competency when we are interacting with different communities. Although you may go to a community with the intention of helping people improve their health, if you're not willing to meet them where they're at and provide information in a way that is suited towards them, that information might not actually be actionable or understood. Another way to improve screening education is by holding sessions with healthcare providers. A lot of healthcare providers do not provide adequate screening, meaning that some individuals will have several risk factors to develop liver cancer, but they don't follow through with the screening process. In addition, some healthcare providers aren't really pushing for things like the HBV vaccine. In Idaho, there was a general increase in HBV infections in 2014 or before 2014, which is what led to that general intervention program. And it was because it coincided with lower HBV vaccination rates. And so, by educating providers on the importance of vaccines as well as the importance of screening, they're better able to share that information with the people who are coming to them for their health care. Additionally, healthcare access limits screening availability. So, a lot of the common diagnostic measures for liver cancer are very invasive, timely, and costly. It includes things like CT scans, MRIs, ultrasounds. And so, if you don't really have good access to healthcare, that might not be something that is accessible to you. One diagnostic measure that is being implemented in some places is using the alpha fetoprotein tumor marker blood test. Basically, if this protein is more present in blood, it can indicate liver disease or liver cancer and indicate that further testing is needed. And the reason why this is being promoted is because since it's a blood test, it's a lot less invasive and more accessible to populations who don't otherwise have access to healthcare. So, for example, this is a method that could be used in programs like what was implemented in Austin with the HCV intervention program there. Another intervention opportunity is addressing food insecurity. MASLD-associated liver cancer is the fastest growing contributor to the development of liver cancer in the United States. And a lot of that does have to do with diet quality and just general physical health. MASLD does occur more among people with lower socioeconomic status and poverty. And because of that, that kind of indicates that there's a systemic gap that's not being met. And that's why we're seeing the rise in liver cancer related to this disease. Also, in general, food insecurity limits self-efficacy of maintaining healthy lifestyles in these vulnerable groups. So, for example, I could know how many fruits and vegetables that I should be eating on my plate, but if I don't have access to fruit or vegetables, or if I don't have the time to cook those fruit and vegetables, that knowledge is not something that can be acted upon. And there are very different reasons why someone might not be able to have access to those fruits or vegetables, but it is something that needs to be considered when we are talking about health education initiatives. Whilst education is always a good step, it's not the whole solution, and we also need to be addressing the systemic factors that are at play. In general, the target population of this intervention should be Hispanic and Latino individuals. In general, they tend to have poorer access to healthcare and a lower socioeconomic status, which has been proven to contribute to increases in mortality rates associated with liver cancer. Additionally, poor cultural competency and intervention methods could limit success, which just highlights that we need interventions that are tailored toward each community. Another reason why intervention methods should be tailored to each community is that different populations might have a different array of risk factors that they're affected by. So there may be a community that has excessive alcohol consumption, but maybe they don't have high rates of things like HCV. And so those need to be considered when you're choosing an intervention opportunity because in that area, a harm reduction strategy for intravenous drug use might not be as effective in reducing rates associated with liver cancer. In general, strategies implemented should focus on addressing systemic barriers that limit prevention and management initiatives. Um, and things like higher prevalence, incidence, and mortality rates are associated with systemic barriers. And so strategies that focus on education but fail to address those barriers might not be as effective. Additionally, public health policies should create protections for use of harm reduction strategies to address HCV as a risk factor, since that is the major risk factor in the United States. Additionally, cultural competency is a requirement for intervention strategies, not an option. Minority groups and immigrants are some of the most vulnerable populations when it comes to liver cancer, and so we should take that into consideration when we're trying to reduce liver cancer. Strategies should be targeted, collaborative, and have a multi-level approach. As I mentioned earlier, this is not a disease that just affects the United States or Texas. It has global implications. And so, through collaboration on a multi-level scale, we can all inform better practices to prevent the development of liver cancer through targeted means. And finally, better screening is needed among at-risk groups to prevent high mortality rates. Uh, in general, if you don't know you have liver cancer, then you really can't do anything to treat or manage it. In conclusion, liver cancer rates have increased over recent decades. These incident rates have nearly doubled in Texas since 1999, and they are the fastest growing cancer-related deaths in general. The shifting disease etiology also indicates a need for adaptive prevention and intervention strategies. In general, liver cancer is something that does need to be focused on as a health issue, both at a state level, national level, and global level. Thank you.